In the invisible currents of air I breathe, a silent traveler floats. The spore of Aspergillus, a common fungus found in soil, decaying vegetation, and even household dust. For most, it passes unnoticed, but for some, it becomes a formidable foe. This is the story of Aspergillosis. Aspergillosis begins when Aspergillus spores are inhaled into the lungs. In healthy individuals, immune defenses swiftly neutralize the threat, but in those with weakened immunity, such as transplant recipients, cancer patients, or individuals with chronic lung disease, the spores germinate. The fungus forms hyphae that invade lung tissue and blood vessels. This triggers inflammation, tissue necrosis, and in severe cases, systemic dissemination. In allergic bronchopulmonary aspergillosis, or ABPA, hypersensitivity leads to mucus plugging and bronchial damage. In chronic pulmonary aspergillosis, cavities form in the lungs, sometimes with fungal balls or aspergillomas. The disease manifests in many forms, allergic, chronic, or invasive, each shaped by the host's immune landscape. Aspergillus is not contagious. It spreads not from person to person, but through the air, a ubiquitous presence in our environment. Transmission occurs via inhalation of airborne conidia, the spores. High-risk environments include construction sites, compost piles, and hospital wards with poor air filtration. Immunocompromised individuals are most vulnerable. One breath in the wrong place at the wrong time, and the spores find their way home. Diagnosing aspergillosis requires a blend of clinical suspicion, imaging, and laboratory precision. Chest CT scans reveal nodules, cavitations, or halo signs. Laboratory tests, galactomannan and beta-D-glucan assays, sputum culture or bronchoalveolar lavage, and histopathology showing hyphal invasion help confirm the diagnosis. Serology, like IgE and IgG levels, guides us for allergic and chronic forms. Each test is a lens. Together, they reveal the fungal fingerprint. Treatment depends on the form and severity of aspergillosis. For invasive aspergillosis, voriconazole is the first-line agent. An IV loading dose of 6 mg per kilogram every 12 hours for 2 doses. Maintenance at 4 mg per kilogram IV every 12 hours or 200 mg orally every 12 hours. Duration is at least 6 to 12 weeks, depending on immune recovery. Alternatives include isavuconazole or liposomal amphotericin B. Therapeutic drug monitoring ensures efficacy and safety, especially with voriconazole. For chronic pulmonary aspergillosis, itraconazole or voriconazole, 200 mg twice daily, is used for a minimum of 6 months, often extending to a year. Long-term therapy is key, and surgical resection may be considered for symptomatic aspergillomas. For allergic bronchopulmonary aspergillosis, prednisone at 0.5 mg per kilogram per day, tapered over 2 to 3 months, and itraconazole, 200 mg twice daily for 16 weeks, are used. Here, corticosteroids calm the storm, while antifungals reduce the fungal load and steroid dependence. In hematologic malignancies and transplant settings, prophylaxis can be life-saving, such as posaconazole or voriconazole during periods of neutropenia or immunosuppression. While I cannot eliminate Aspergillus from the world, I can protect those at risk. Using HEPA filters in hospital rooms and ICUs, avoiding exposure to soil, dust, and decaying matter, prophylactic antifungals for high-risk patients, and close monitoring of immunocompromised individuals all play a role. Prevention is not silence, it's vigilance, filtration, and foresight. Aspergillus is ancient, airborne, and everywhere. But with knowledge, vigilance, and care, I can breathe easier and help others do the same.